All right. So that was the first part of Crib's scope of work. Second part is, like I talked about, we will be initiating a CTCCCP coalition and an advisory group to write the Tribal Comprehensive Cancer Plan. And so all the tribal health programs will serve as the advisory committee or the advisory group to CRIBS CTCCP, but we'll also have a coalition. That coalition is not limited to just tribal health programs. You guys are automatically part of that coalition, but that coalition gives us a chance to recruit, academics and other institutions that can sit on our coalition. For example, if you have a connection with an institution or someone at the institution that you think will be good at writing or providing information or guidelines to writing the comprehensive cancer plan, we will invite them on, and you guys need to identify those, and I'll also be identifying some of those individuals so we can have a pretty good broad coalition so we can represent whole California at least, and write a tribal comprehensive cancer plan. So I'll be in touch with you guys on that, on how we can do that later. We'll be supporting tribal health programs to develop protocols to ensure implementation of community chosen educational strategies and culturally adopted PSC changes. That will be done through work plan development, and through our phone calls and support like that. We'll also be providing training to tribal health program healthcare professionals about cancer survivorship issues, can be from diagnosis through long-term treatment effects and all the way to end-of-life care. So everything that encompasses, we'll try to identify trainings, or you guys can bring up topics that you would like to study more about and learn about, and then we can train everyone else, or we can just identify them and then we can try to find someone who's already an expert and have them come on either our monthly calls, or we can set up separate webinars or meetings, like we have the wellness coming. So on the wellness, we also have 2 presentations, which I'll talk about that later. But those kind of venues we can use to educate ourselves more about the cancer topics at hand. So what are the responsibilities in the tribal health program scope of work? You'll also be assessing the community needs and strengths. Obviously, when you do that, you relay that to us, so it's kind of intertwined in that sense. Identify gaps in cancer prevention and care, assessment of communities' comprehensive cancer control readiness. So you'll also at the same time be measuring, is the community ready for this evidence-based intervention? If so, we'll move on forward. If not, you can wait until the community is ready, or find a way to get the community ready. Or if it is actually not an applicable evidence-based intervention at all, then we can skip that and not apply that in a community. So it's going to be a very intertwined program where we listen to you and we go back and forth a lot, and see what fits for the community and what doesn't. We'll be establishing with you guys together a baseline data, like I said, for LIDS, and that doesn't include only EHR data that we'll work together with you in pulling and analyzing, but also administering surveys and interviews to know the community better and see where everyone is. Again, participate in monthly advisory committee meetings, which we'll set up soon. That we'll meet monthly to update on what's going on, what's working, what's not working, what we can do to support each other. And also, I said bi-monthly tribal comprehensive cancer coalition meetings, but I think that might be too much for us to meet every other month on the coalition and then also the monthly advisory committee. I think we could probably do is we can have a monthly call with the advisory committee, another monthly call, and the third month's call every third month. Instead of having the advisory committee meeting, we will just have a coalition meeting where other people can also join in to our meeting. So it'll be one, the first one every third month we would have a coalition meeting, but the first and the second month we'll always have the advisory committee meeting. And it doesn't have to be long. This is, you guys can always tell us, hey, we're meeting too much, this is happening. You don't always, you can tell us, and we'll be responsive to that, and try to mitigate that problem if that is one. We don't have to meet for an hour if there's not, if there's a lot of stuff going on, there's a lot of actual work going on in the community. You don't have to meet that time. It's not a requirement. I mean, it is a requirement, but if there is something that comes up, you can skip it, or you can just update or send a written report. We can work together on find another way to know what's going on in the community. And one of the biggest components in this scope of work is to assist in writing and implementing the California Tribal Comprehensive Cancer Control Plan. So I keep bringing that up because that's going to be a big component of this. CDC had originally perceived that we already have some kind of coalition in place, or a work group that is already working on this comprehensive cancer control plan, but that is not the case. We don't even have a draft. No one in California has worked on a comprehensive cancer control plan, even a draft or a guideline. So we don't have anything to go off. I am working with other organizations outside of California that might have some groundwork done that we can use as a skeleton. For example, in Portland, Northwest Portland Area Indian Health Board, they have theirs. We can look at theirs, and there's a few other programs that already have this cancer control plan ready, and we'll look at theirs and we'll go from there. And all this is already part of the contract, so if you need to look there, you can look at that too. Another, this is more on the community level. So this TH tribal health programs will be providing community education and implement effective PSC improvements to address comprehensive cancer control by emphasizing these four priority areas. The first priority area is to emphasize primary prevention of cancer. The second one is to facilitate screening and early detection of cancer. And then we have improving cancer survivors' quality of life, and also promoting health equity as it relates to cancer control. These are pretty broad areas, so that is why we want each tribal health program to not just have one staff, but also have that staff work with multiple other programs and areas, so they can get staff that are expert in primary care prevention or screening, so we can combine all those resources and address all four priority areas. I'll go into details now what that would look like. For emphasizing primary prevention of cancer, we have the project period objective, which is called the PPO, and the annual objectives called the AO, and then we have the LIDS indicator. Like I was talking about, that's kind of an evaluation measure to see where we are. These are for us at CRIB. That's what we need to do to reach our goals. And the way we can do that is by working with all the tribal health programs, right? Not everyone is going to be addressing every area, every year. So what we need to do is sit, down together, and when we look at the work plan, I will go and look at I'll show you guys how we can do that at the work plan. We'll set those baselines and targets, and the current measurements at each tribal health program, and we'll do that by working with the medical directors or the EHR staff and see where we are, and we can combine our efforts so collectively we can reach this goal over here. And by the way, if you have any questions, go ahead and raise your hand or just speak up. This is, not a hardcore presentation. This is more of a communication channel between CRIB and all the tribal health programs. So feel free to just, stop me at any time. Tell me to be slow. Tell me, hey, how does this work? Please feel free to do that. And you can also, do that during this presentation, or pick up your phone anytime and feel free to call me, and we can figure it out together. like I was talking about EBIs. EBIs are the evidence-based interventions. For year one, we have under emphasizing primary prevention of cancer, we have 3 EBIs. And the first EBI is multi-component interventions to increase tobacco cessation. Now, I have tried to pick the most broad EBIs because that lets you be in charge of selecting what kind of activities that you want to do in your community, because I don't want to just pick something that doesn't work in the community. So I tried to be as broad as I could, selecting these, so you'll have more of room for selecting what would fit in the community that you work in. And the second one is mass media education campaigns to reduce tobacco use initiation. Again, this is pretty broad as well. You can do any, campaign that you want using mass media. And there's so many different campaigns, like the tips campaign, would also come under there. So if you wanted to put something in your monitors, in the waiting rooms, or in wherever in any other community rooms, you can contact me. Hey, I want some in tips campaign materials. Could you send those to me so we can put it on the monitors? So anything like that would work under there. You can make your own media education campaigns. You can start a Facebook group or anything like this. Would work in the community. So again, it's very broad, and you can collaborate that with other programs, or you can reach out to us, and we can collectively set up a campaign and go from there. This one is a little more specific, as I do want interventions that have worked in a lot of communities and are very successful. And one of them was provider reminders with provider education to increase tobacco cessation. In this one, you will be setting reminders for the providers, and you will figure out a way to do that. How you work in your system. That could be, through emails, or it could be through, I would prefer, a systems change where, every so often they get a response through, in their records that, go ahead and use these materials when you are talking to your, smoking patients or patients who smoke. The next one is to facilitate screening and early detection of cancer. And the PPO for that one is to increase the percent of adoption of evidence-based tools to 30% by June 2022. And the annual objective is to do the same thing by 10%, the LIDS indicator being adoption of, obviously, the evidence-based tools. I am trying to, at this point, ask CDC if they can provide us a list of evidence-based tools. A lot of these evidence-based tools are already being implemented in a lot of tribal health programs. So what we will be measuring is the new ones that we can introduce. So for this one, I'll try to work with organizations like American Cancer Society or Every Woman Count and see what their recommendations are. And I've already, in a few calls that I've made to some of the tribal health programs, they have identified, so this organization tells us to do it this way, and there's another organization that tells us to do it this way, which way we do it. So we're going to try to work with those organizations and have them present to us and have them train us what kind of evidence-based tools they recommend. And if we don't have some of those tools already being implemented in the clinics, we will take them and we can try to implement those at the clinic. So that new tool that becomes implemented is something we will track, so we can have a good understanding of how many new evidence-based interventions we're making in the community or in that tribal health program. Again, please feel free to ask questions. If I'm going too fast, I can slow down. Am I going too fast? Is everyone understanding what I'm talking about?
I understand.
I understand.
You're good.
We understand.
Okay, good. Thank you. It's just want this to be a presentation. I want this to be a conversation again. And so evidence, so we talked about our goals. Next we have the, what kind of EBIs we have under, facilitating screenings and early detections of cancer for EBIs. So, patient navigation to facilitate timely screening is a huge one. I've had conversations with some tribal health programs, some of you already in presence, Some of the medical providers there have said, we used to have this navigator, this nurse or this community health worker that used to do this, and this. And I thought, this would be a good, evidence-based intervention to keep. And they would be like, hey, the person didn't have funding, so now they no longer, work at, in patient navigation, or they no longer work there. So we need to establish, some kind of, venue where we can have a patient navigator, present at all times, so they can facilitate timely screening and do also, other things, like make appointments or follow-up care, or, for example, trying to remember which tribal health program was. It might have been Skip. I don't know. But where they had a navigator who, who would set up appointments, and they would also follow up with care, see if the patient, because a lot of time in cancer, after diagnosis or after, treatment, you get referred to cancer care providers, and a lot of people don't check if the patient actually went to the provider afterwards. So they had someone who would actually check. So these are kind of the things that a patient navigator can do, and they can be funded through this program, and they can get their whatever, how many hours they need, they can get it from this grant. And again, I'm sure you've noticed, unlike other programs, I haven't asked you for a budget or anything like this. So this is more of a partnership, a collaboration, not, like we are funding you to do this, and this. Are you doing this? This is more of like, what do you guys need? Can we do it? Let's do it together, kind of program. So it's going to be a fun one. I hope you all enjoy working on this, because it's going to make a huge difference in our communities. Next one is to, again, smart media to increase community demand for cancer screening and services. Cancer screening is a huge topic. A lot of people don't get screened, so we can use small media to accomplish that. And again, that could be multiple ways. You can come up with your own campaigns, whatever you want, or already use campaigns that exist, like wearing blue for colorectal cancer. I'm kind of wearing blue. I'm always wearing blue, but on March 2nd, that's what was supposed to happen. So that could be another campaign that you guys can develop, something simple, and then but you advertise it enough that people get aware of the issue, and then they reach out to you and schedule for a screening. Something like that would be great. Again, another one for cancer screening is group education to increase community demand for cancer screening. So if you have patients come to your, I know a lot of people have diabetes, education classes, smoking cessation classes. They have thousands of different classes, right? And also we have patients in the waiting room. How can we get them to come to us where we can get them in a group and educate them about cancer screening? You can do this with this, evidence-based intervention. And you can say, yeah, we picked this evidence-based intervention, so you can take it to your medical director or CEO and ask them for permission to educate, whoever is participating in some of those classes. Hey, and ask them, hey, can we educate them also about cancer screenings? And obviously, if you don't have expertise, we'll try our best to provide those services to you. And educate whoever needs to be about cancer screenings. Next one is a little after screening, so it kind of follows a pattern. I guess prevention, screening, and now survivors' quality of life. So how can we improve a cancer survivor's quality of life? Our project period objective is to increase the trainings on cancer survivorship for health professionals and paraprofessionals to 30% by June 2022. And same for the annual objective, but by 15%. Obviously, the lead indicator for this would be trainings on cancer survivorship for health professionals and paraprofessionals. What would that look like? You can host trainings at your clinic to increase the number of healthcare professionals that are aware of survivors' quality of life and all those issues, that I'll talk about in a little bit. But you can have those trainings hosted at your clinic, or you can also come to trainings. You and other healthcare providers that work on our grant can you can fund them to go to seek trainings on survivors' quality of life. And also, for example, at the wellness conference, that is what it is. We have 2 trainings on comprehensive cancer. One of them is actually on cancer survivorship and how to make care plans for cancer survivors. So those trainings would count under this, because once you have your healthcare professionals trained on this, they can actually take that information back home, either train other clinical staff, but just enough they can also work with your patient with a better understanding of how that mechanism work and how cancer survivorship works. So that in itself is enough, but if they can also educate the staff at the clinic, that's a plus. And I hope you can come to the wellness conference. It's actually part of the contract. So I guess you have to, and take information back home and give it to your providers, and hopefully they can benefit from it. And the evidence-based interventions under this priority, we have again 3. So 3 evidence-based interventions for the priority area. That's how we've done our work plan here. So first one is to establish or disseminate guidelines that support quality and timely services provision to cancer survivors. Just like I was talking about earlier, can you establish some guidelines, or if you don't have the capacity to establish the guidelines, you can disseminate those guidelines to your providers, and that would also be beneficial. Establish clinical practice guidelines for each stage of cancer survivorship. So for each stage of cancer survivorship, you can establish a clinical practice guideline for your providers, that what they need to do once they have someone who's a cancer survivor. What are the steps? So that would be another one. And as educate healthcare providers about cancer survivorship issues, from diagnosis to long-term treatments, effects, and end-of-life care. So are the providers aware of all the information and all the support available to cancer survivors? Can they recommend that to the cancer patients? So those are the things you can work on. And for this one, you can be as creative as you want, and again, you can see these are very broad. These are not just like, we will be doing this and this and this. This is very broad. You can, select these. And also, as I will talk about in the work plan, I'm not going to hold everyone, accountable for like, hey, did you do this? The work plan, you can change, if something is not working in the work plan, you're free to change that and update me, and it's like, hey, by the way, this right here in our work plan, this activity wasn't working, so we don't do this. Instead, we're doing this. So you can work with me on that, and we can hopefully try to find the best fit for the community. Then we have the last one, is we have to be mindful of the community that we are making these interventions in, and to the individuals from that community. So how can we be adherent to that, is to promote health equity as it relates to cancer control. Our project period objective for that is to increase the percent of population with regular healthcare provider by 20% in 2022, and 10% by this project period. And obviously the LIDS indicator for that is population with a regular healthcare provider. So what does that look like? After talking to a lot of the EHR people here and some of the medical folks, I've learned that not everyone gets assigned a primary care provider. That is what a regular healthcare provider is, someone who can provide primary care. A lot of people don't get assigned a primary care. How can we increase that? That's a systems change. So if we have, primary care providers that get assigned patients on the basis of like, this person just came in, who do we have available? We'll just assign it to, that person. And for that day, that's their primary care provider. That doesn't give us continuity of care, which in research has shown over and over that in all populations, that is a great way to increase a person's health. So we need to move toward that way. And how can we do that? We know who the people are coming to our clinics, so we can divvy those up and assign them to primary care providers. because the clinic has the ability to do that, to assign patients that come up a regular primary care provider. I know a lot of insurances, they kind of require you to do that, but a lot of people that just come, they don't have that, that luxury to see the same primary care provider, and the primary care provider then can become part of your, health, not just, for that day, but if you have an assigned one, they can become part of your health, so they can continuously, work with you and manage your health, and also catch mistakes that if you see, a healthcare provider for one day would not be able to catch, because they don't know anything about you. They don't really have a good history. They might see a chart of you, but they might not be able to see the history that you can establish with, a primary care provider. So that is a huge, important issue in this, program. So hopefully we can try to work with our clinics and increase the number of, patients that are assigned to a primary care provider. Some of the other ways to use to increase that is to also have the patients, if they have the option to select a primary care provider or assign themselves a primary care provider. Some of the ways to do this would make sure that all their needs are met and all their and it's equitably done. And some of these, strategies, I've written them over here. They're also evidence-based intervention. So, for example, use of linguistically and culturally appropriate health education materials to promote health equity. That increases health equity. And for me personally, if I see a provider who is going, above and beyond at the clinic, or a clinic even is going above and beyond, and meeting my needs and is being very professional and very, very culturally competent, and the clinic is carrying a lot of education materials that are, competent to me, obviously I'm going to pick that clinic or that provider over anyone else. So that would be one way for that patient to look into how they can actually assign themselves that provider, right? Second one would be culturally specific healthcare settings to promote health equity, like I was talking about settings, and you can be creative on how you want to change those healthcare settings and systems to meet the needs of that community, so the patients are more comfortable coming to you and also asking if you can be their, assigned primary care provider. Again, very similar cultural competency trainings for healthcare providers to promote health equity. Do we do that with our health care providers? Do we send them to trainings where they get culturally competent, cultural competency trainings? I don't know. I don't even know, how that works at the clinic. So that's what I want to learn from you guys, and figure out, are all the clinics actually providing, cultural competency trainings to their healthcare providers? Because sometimes a lot of the new ones, right out of medical school, they are not, as aware of a lot of cultures and how to work in, different cultures. So are we providing them with the training? Are we providing them with tools to be successful in their practice? So that's something, we need to work together and figure out. And if there is a clinic, for example, that is providing that, we can learn from them and see if we can, get some of the, the people who are providing those competency trainings to come to other clinics and also train the staff there. So we need to figure out a systematic way of doing that. So that's another evidence-based intervention. That's a really good one to increase number of assigned primary cares to people. What are the technical assistance trainings available? For tribal health programs, we are, able to provide in-person and virtual trainings on comprehensive cancer control, training and assistance on work plan development and implementation, which I'll talk about, today, and training and assistance on data collection and assessment. We have CTEC, at right across my desk, we have CTEC, the Tribal Epidemiology Center for California. And if you need help with, data assessments and data collections along the way, they're there to help you with that. And also, as you will see, I'll talk about, EHR data that we would be requesting. We already have, data sharing agreements with all the clinics that I'm speaking to today, or we'll be working with in this program. We want to work with each clinic to get that data and analyze it and give a report back to you to figure out the incidence, prevalence, and also treatment rates and everything, screening rates, even to figure that out, and how we can increase some of those and decrease the other ones, to see where we are and how we can improve. We can do that, and we will be requesting data from you guys, and analyzing it in-house with our epidemiologists, and give you a report on where every clinic is, and individually every specific clinic is. We'll also be able to provide in-person trainings on cancer survivorship issues from diagnosis through long-term treatment effects and end-of-life care, which is, again, I'm talking about in the wellness conference. We'll have someone present on that on the second day. So I am hoping at least 1 to 2 people can come to that training, and I'll talk about that training in a little bit. But we have on this program, as of right now, just me, which is right here. So hey, Barif, that's me. If you were wondering what I look like. We also have Kathleen Jack, but she'll have more of a project director, a very broader, scope of work, where she'd be kind of managing the program through me. So she wouldn't be, doing the day-to-day activities. That would be my role. We'll also have a program evaluator help with evaluation efforts for us as a program, and also programs, also the tribal health program. So he or she will be providing, that support. We don't have a tribal program evaluator for this program yet, and hopefully we can get that, because a lot of those reports I've been doing, so that takes away time from you guys. So hopefully we can get that soon and get going. The next thing I want to talk about, does anyone have any questions before I move on to the next thing?
Nope.
Adriana?
No, I don't.
Salam and Catherine, no, we don't.
Okay, good. Then we can move on to the next thing. We have the, it says, as you can see in the watermark draft, I've been working on it, but I haven't gotten it through our internal review. So, but it will be, it's gone through our internal review departmentally, but as CRIB has now, we still need the CEO, the COO, and a few other signatures before I can actually share this with you guys. So this is what I have, but it will be pretty similar to this. It won't change much. Maybe a few wordings will be changed. And we'll be using this as a guide for our activities. I requested the information. So this is what the template will look like that you'll use, and send information back to me. Can everyone see that?
Yes.
Okay.
Yes.
Good.
Yes.
It's pretty blurry, but we can see kind of what's on there.
Let me see if I can fix that. Audience view.
But we can make, yeah.
Better?
Yeah. Oh, better. As you make it bigger is better. Okay.
All right, we'll go from there. So as you can see, the first page is requesting a lot of information about doing what and what kind of role they have. And if you have multiple people, please feel free. Like you have, if for example, Salam and Catherine, you have very similar roles as like maybe you guys are the project lead, then you can put your both information there. Or if you're the official project contact, you can put your information there. But basically what I'm trying to do is understand what's going on at the tribal health program level, so I'll know who to contact when I need things. Because not everyone will be able to do everything, so that's why I want to have a broader perspective of who to contact when I need to. The first one is the contact information about the tribal health program. The tribe is represented, the name of the tribal health director, which would be someone who's kind of like the CEO. For example, for Thule it would be Zahid Sheikh, and the information also when I need to do a site visit, so I know where to go, so I don't go to a random place, that kind of stuff. And then we have the official project contact when I need official approvals, or someone who I can officially contact, who will always respond. That will be the official project contact, and I need the information. Project lead, if different from the project contact, because they can play the same role, would be someone who has day-to-day activities assigned to them. So if I need to see, what's going on, I can, contact that person, or I can, contact that person for support. If someone else asks, hey, Thule is doing this, I want to figure out how they're doing this, I'll call someone who's a project lead about that. So that would be their, role. Medical director is someone who is the medical director, not the public health director. This is someone who's specifically the medical director for that organization. Someone who could be the chief, for chief of medicine. I don't know how do you guys assign those roles, but someone who has authority over the medical day-to-day activities. That would be the medical director. So that's what that is. On top is the tribal health program name, which would be your tribal health program name. Workplan and CTCCCP, you can leave that on there as it is. And by the way, this will be a MS Word document, so you can edit it. This will be a header, so you'll double click and you'll be able to edit that part and put your own name in there, the official name. Right here it says 2017 to 18 work plan. We started late, so that's hopefully it will be different next year. Project 1 year, year 1 project period. It ends in June 29. Some of you guys started a bit late, so please look at your contracts and figure out the starting date for that. And on right here for us to track the date created, when it was created first, and also if you, like I was saying, this is a living document, and if you need to update it, go ahead, please do, and send it back to me, and and you can put last update there, so I know I have always the original and the newest copy for that. Again, when you do progress reports, that's also when I do want to see this again, because as you'll see in the in this right here, when we do have activities, you can mark them as complete, incomplete, or in process, so I know what's going on, and I can find a way to help everyone if there is a hiccup in there somewhere. This right here is the tribal health work plan's template, directions, and glossary. I've already told you guys what the program strategies are. Those were the 4 top ones, like cancer screening, primary care prevention, and those. And the evidence-based interventions are those strategies, the small ones, the 3 under each program strategy that we will be utilizing. For first year, you are to select at least 1 EBI. Every single tribal health program will select 1 EBI. Year 2 to 5, at least 1. So if you want to select multiple, please go ahead and select them, and we'll try to get as much as we can done. Year 2 to 5, we will require implementation of multiple EBIs, and that's how the program will work. That huge word that we use, the library of indicators and blah blah blah, which we call it, I've kind of simplified it and just called it the health improvement indicators, so we can actually talk about them. Those are long-term outcomes related to reduced risk and increased use of early detection services, improved quality of life among survivors. Will measure the overall impact of the awardees' activities. And please work with me and our staff, your medical director and EHR staff, to collect the baseline data and a yearly target, which I'll show you on the next page what that would look like. For the patient population size, we have identified as number of American and Alaska Native patients registered at the tribal health program. So all the patients who are registered at the tribal health program, or you can also say the ones who they're not registered at the tribal health program, but they continuously use those services as well. That's the clinic they always come to. Yeah, you can count them as a patient there. I want a tentative site visit date. What that would be, and multiple site dates. Please, recommend them to me because there's a few programs it'll be overlapping. So please identify a few of those dates, and we can try to figure out a best date to visit your place by June 29, 2018. That's when I want to come and finish all the site visits. The timeline is the activity start and end time associated with that activities, and then activities are actual events or actions that take place as part of the program, and they will be under EBIs. We want to also know the short-term outcome measures, short-term outcomes and measures, and here's the definition. These are your target for the population. After you implement a certain activity or an intervention like the EBI I've been talking about, or an activity, under an EBI, which can, measure the change in knowledge, skills, or attitude of the population, and yeah, so that's what that is. We also want to increase partnerships and use of resources through this program. So we're looking for you to partner with the organization. So that would be collaboration with other agencies and programs. And there's a progress column that you can use for submitting progress reports and final report, like I said earlier. So before I go to that, I want to talk about this part right here, which is very important. So this right here, I kind of made it easy by making it into steps. So step 1, please select at least one EBI by checking the box below. These right here are clickable. Let me actually open one. It's not really clear on Word, so that's why I didn't use it. But when you do go on the Word, you're able to. So this is the Microsoft Word portion of this, right? Right here. When I go there, I can, as you can see right there, I can actually click. I don't know why I can't do that. Terrible example, but you will be able to click on there, believe me. So all you have to do is just click on there, and a mark will show up, and that way I will know which evidence-based intervention you will be picking. So all you'll have to do is click. If you're doing multi-component interventions to increase tobacco use cessation, that's our EBI 1. Click, and then you can select that. And you can select as many as you want, but obviously don't go overboard because we want you to be able to complete as much as you can. So, so again, those are the strategies. These are the evidence-based interventions under those strategies. So we have 4 program strategies, and every single one of them has 3 EBIs attached to them. So when you do that, you can select them, and then you can copy and paste them in here, and I'll tell you how to do that later. So the next part of this is the LIDS part, where I was talking about the health improvement indicators, as we will call them internally with our program. We have 4 of those. We have the adults who use tobacco, the adoption of evidence-based tools, training on cancer survivorship for health professionals and paraprofessionals, and then you have population with a regular healthcare provider. This right here is the inclusion criteria, which we will use to see which of those criteria need to be matched for us to track those health improvement indicators, right? For example, for the first one, when you're running your electronic health records, you want to, for adults who use tobacco, we want to have commercial tobacco users only. So stay away from marking. If there's a marking for traditional tobacco, we're only looking for commercial tobacco, not traditional tobacco. So what would that include? That would include smoking, chewing, and sniffing of commercial tobacco and cigarettes, that kind of stuff. Second, age greater than or equal to 18, because we're talking about adults. That's how we have defined them. So that would be another check on the EHR. And we're also only looking for American Indian Alaska Native patients. So these are the criteria that needs to be met for each LIDS or each health improvement indicator. On here we have the baseline. The first time you run the data on the EHR, you will get a baseline. For this the baseline is 0 because we want to start from the 0 because evidence-based tools, you already have them being implemented at your tribal health programs. It'll take us a long time before we figure out all the evidence-based tools that are being selected. And also, I don't know how many trainings are already happening at the tribal health programs on cancer survivorship. So we'll also start that from 0, and we'll only count the ones that are due to our program being implemented at the tribal health program level. So over here, you'll get a baseline in, percent for adults who use tobacco, and population of the regular healthcare provider, you also get a percent. You can, for population with the regular healthcare provider, you have the American Indian Alaska Native patients. That's the first. And again, another inclusion criteria is the percent of patients with an assigned primary care provider. It has to be assigned. Patients without an assigned primary care provider are not considered to have a regular healthcare provider. So please make sure the HR knows that we're looking for assigned primary care provider patients, and that would also be a percentage. And then we'll call that our baseline forever, and then we'll go to current measurement. So when we run the report second time, right, we will see what are the percent of adults who use tobacco the second time, after intervention has been, done in the community. How has that changed? And we will continuously run that report, in the EHR when we want to, see, or when, we are requested by CDC, or we want to know, where we are currently. That's what it would measure. And then we can look at the baseline and see how we actually deviated, improved, or, regressed from our current data, which is the baseline data. And then we have the target. The targets needs to be established when we, probably under either during our meetings in person, or through, calls, and, these meetings like here on computers. We need to figure out a target where, we work with you guys, but also meet the target that we set for ourselves as, CRIB. So we'll need to figure those out together, and those targets will be reflected on, like the ones we talked about for our annual objective, and so that's the targets we're talking about. So we'll need to set those together. Again, on the bottom we have the AIAN patient population size. Again, number of AIN patients registered at the tribal health program only. We can put that in this box. It will be editable, in MS Word. And tentative site dates. Select multiple site dates and put them in here, and I can see which ones don't conflict with all the other site visit dates, and hopefully we can set up a date and show up. Next, we have a tool for you to track your activities on a work plan kind of outlook right here. So for example, here it says EBI. You will go up and see that you selected, for example, one of these. So you'll copy that, copy that EBI and bring it down and paste it right here, right? And I have, a lot of them here, a lot of different boxes. So you can use different boxes for different EBIs, right? And you'll copy them and paste them in there, and that will help you track the activities you want to do for each EBI. For example, if I want to do multi-component intervention to increase tobacco use cessation, one of the activities I can do is the CDC tips campaign. I'll have a timeline for that, the staff that will work on it, the short-term outcome measures, and the partners I will need. And when you are giving this back to me, for a progress report or a final report, you'll say complete. If you've done it, incomplete. If you haven't even started, in progress. If you're kind of working on it, but you're still need time, so that you can use, and you can send it to me after. So that's what that would look like. So please use this to kind of put a layout for yourself, and you can have multiple activities for EBI, and you can use multiple EBIs as well. So that's kind of where we were looking at for that work plan. Does anyone have questions about the work plan? This is again a draft. I will send you the actual copy of the work plan as soon as we can get it through the internal review. Does anyone have questions about the work plan?
No.
No.
Okay, good. All right, so we'll move on to the next agenda item, which is the save the date for wellness. like I said, in the contract, one of the required thing is to attend at least one meeting, at least one um, at least one conference hosted by CRIB, and this one is the one that we were hosting that we would like everyone to attend. It's increasing our wellness vibe is the conference. On the first a few days, Acorns is putting up their own resource meeting, and the one that you're required to attend is the wellness conference, which is on the second part on the right side. Can everyone see which one I'm talking about? The wellness conference.
Yes.
Okay, so that is has a pretty huge focus on Tribal Comprehensive Cancer Control Program. We'll have two presentations. One is on HPV vaccination and HPV itself, the virus, and the other one is on survivorship. We'll also have a meeting there for all of our advisory committee members to meet there, and I'll have an agenda, as well for that. So we'll have 3 activities related to Comprehensive Cancer Control Program that I would like everyone to attend. So mark those date, and hopefully we can get 1 to 2 people from each program. Hopefully someone who's going to be the lead on the project, and possibly a provider or like a medical director who's going to be very involved in this project. So hopefully we can get a few of those people over there. So 1 to 2 people. If you're attending, please fill out this registration form. And just for the our subcontracts, us partners, the registration is free, and we will pay for lodging, and we will pay for the travel, and we'll pay the per diem. So your travel and everything is taken care of, for this program. I'll send this. I've already sent this to everyone in the email. Does everyone have this form?
Salam and Catherine, we do have the forms.
Okay. So is this, and make sure that the one that you do have says this at the top: registration for CTCCP subcontracts. And because for other programs we're not paying for per diem or travel, and we're only allowing one member from each tribal health program to attend if they're not part of the CTCCP. So, but if you are, you can bring 1 to 2 staff that are part of our CTCCP or your own program, the people that will be working, other than the other one person that might be attending. So this is just for the CTCCP folks. You can bring 2 people regardless if you already have people coming to the conference. So again, to emphasize, 2 people, 1 to 2 people, you can bring them. You can put the nights on there, and request the room that you want, and also the vehicle you will be using, the GSA or your personal vehicle, and the estimated cost, and the miles for round miles. So the departing date and the date returning. So provide us with that information as soon as you can, because I have to request internally at CRIB for everything. There has to be a specific PO that needs to be done for my participants because we're paying for everything. So please do this as soon as you can. 1 to 2 members, and we'd love to see you there. Do you have any questions at all about anything we've talked about today? Could be the presentation, our work plan, and save the date, or our wellness conference. So anything that you have questions, please go ahead and ask now, or give me a call anytime you want. Send me an email, and I'll be happy to respond.
Hi, this is Salam and Catherine. Thank you very much for the presentation. Are those going to be sent out via email sometime soon? Because we couldn't really read some of the prints.
For the
your slides, yeah.
Yeah. I'll send the slides over to you today. And
okay.
The work plan, however, I will probably send next week because it's still going through internal review. And I'll send another save the date and also the registration form also to you. yeah, and that's about it. So, and I encourage you to attend both days again, and hopefully we can, see everyone and, come up with a collaborative strategy and address cancer disparities in Indian country in the next 5 years, and hopefully, keep doing this because we are kind of behind as California tribes because a lot of other programs have had this kind of effort for 20 years. For example, North Portland Area Indian Health Board has been funded for 20 years. We just started like this year, and we're so we're super behind in these efforts. So hopefully we can get kicking and get to the same level as all the other organizations.
Okay, thank you. And then the other thing is, you wanted a date for a site visit. How soon? Like in the next 2 weeks, or I didn't catch the date. The time.
Okay, so I was thinking. So go ahead and send all the days that you are available after the 2 weeks, and make sure they're not wellness dates. And then if I do have a conflicting date, I'll reach back to you and tell you like, hey, by the way, we're having another conference. So send me as many dates as you can, and I guess 2 weeks from now, or actually make it 3 weeks because I do have to ask for travel and everything. So after 3 weeks, send me the dates that you guys have available.
Okay, and then my other question is the dates. On the bottom of the I wasn't sure if the work plan sheet, it has like the June 2017. Is that going to be changed March of 2018 to 2019? What's the time frame?
The year?
No, the one to my right. So the 2000 dash, yeah. Mm-hmm.
Okay, so it's 2017 to 2018 because that's when how our program is funded. Like CDC, the work plan is from 2017 to 2018. It's just we received a really late notice of award, so it took us a while to get it to all the tribal health program.
Okay.
It will stay like this, and because we want to know which year we kind of are in. And then for next year, it'll be 2018 to 2019. Next year, you'll start a lot earlier, like a lot earlier, and you'll have a lot more time. And again, I keep saying this, the funding, hopefully we can keep it next year and, increase it. And also, we won't be able to, I don't think, spend all the monies this year because we have very limited amount of time left. So we can, keep that funding and use it next year.
Thank you so much. We have no further question from Salam and Catherine.
Any other questions? Adriana?
I don't have any.
Looks like we are, about to close, and so we had about, 3 different health programs join. I'll try to reach out to the other 3 as well and see if we can set up another meeting. And hopefully we can try to do this every month to see where everyone is and what kind of help everyone needs. And, together we can, come up with a solution or, try to improve whatever thing needs our attention. But with this, if we don't have any questions, we can, close. Thank you guys so much for joining. I'm really excited for us to, finally get started. I've been trying to, push this as soon as I can, but it's taken us a while to get it figured out at Crib and get it to everyone over there. So thank you so much for joining and being part of this project.
Thank you.
Thank you.
Thank you.